So thank you, Karen, and thank you, Brian, for asking me to present this. So one of my goals was to surprise Karen, so she doesn't feel like, oh, it's the same old talk again. So Karen, I may have a few slides that you may go, what the heck is he talking about? So anyway, so this is an area that we have been actively working on in the recent years. As you know, our geriatrics gerontology group here in COA as well as Bayview, we have been extremely active in the area of frailty research. And without uh, being overly modest, I would say that we are probably one of the leaders, if not the leader, in the area of frailty research. So this is a relatively new area for us, but as I will show, there is a lot of overlap with all the knowledge and the expertise that we have gained over the years in terms of trying to understand what frailty is, how to characterize it, what are the risk factors for frailty, what are the consequences of frailty, and so on. And so we hope to extend our understanding in that area into this new, relatively new area of resilience. And I just wanted to, be a little bit skeptical, although I'm super excited about this, but I just want to always keep this in my mind. Is it just another passing fad, or is there some real substance to this? By that I mean something that can really help us understand the aging process in a deeper way, as well as contribute to the well-being of older adults through this, by studying through this framework. So that's something I would want to examine a little bit in this talk. So I wanted to express my gratitude to Karen, Jeremy Walston, Brian Buddha, and Chen Li, who have been longtime collaborators with me on this. And also thank NIA for giving us the funding and the opportunity to study this. So this is, as you can see, it's like two-phase study. Phase one is a pilot study, which is UH2. And this is the second phase of the study that we are currently started. So we moved on from the pilot into the real large-scale study now, which is UH3. So before I want to get to resilience, I just wanted to present a brief history of how we got here. This is my way of trying to make sense of what I am doing now, because I always like to go back and see, a lot of great people have thought about issues. And so, if we are making any advances, that's because, as Newton said, we are standing on the shoulders of giants, So that's why you're able to see farther. So I just wanted to see what went before and how we got here to this latest paradigm of resilience, right? So Jim Fries wrote a nice article about compression of morbidity, and he basically broke down the advances of the 20th century into three eras. The first era, which was probably pre-World War I, 1900s, 1910s and 20s, he called it the infectious disease era, where we figured out how to deal with tuberculosis, smallpox, and other infectious diseases, which really brought down the mortality tremendously. And then post World War II, there was a relatively stable period. So there was a lot of research in terms of figuring out chronic diseases. So people started understanding heart disease, cancer, diabetes. So there was a lot of research activity in that area. And then more recently, like in the 70s, that's my estimation. Somebody might argue it's probably a little bit before that, or that I would say the aging or senescence era. Um, and there's a nice paper by John Morley in 2004 in Journals of Gerontology, where he sort of chronicles the history of geriatrics in Europe as well as USA. So I think the Baltimore longitudinal study on aging was probably one of the first studies to really emphasize trying to understand aging from a longitudinal perspective. And so Nathan Schock and Ruben Andrus were, giants in that area. So in the late 1950s, the BLSA started. And then it wasn't, it was quite a many years later, it was only 1974 that NIA was founded, and the first director of NIA. As many of you might know, I mean, he's one of the major contributors in this area. And then in 1982 was the first department of geriatrics in Mount Sinai. And again, Robert Butler was the chairman of the department. And in my view, probably one of the first influential papers in modern geriatrics was Jim Freese's New England Journal paper on compression of morbidity idea. So that's sort of a brief history of work up to Jim Freese's compression of morbidity, and then I will look briefly at the evolution of concepts. So Jim Freese's compression of morbidity provided a major conceptual advance in geriatrics. So where he was talking about the goal of geriatrics is not merely to extend lifespan, but to really make people healthy until the last years of their life. So he has this model of one horse shay that I talked about in one of the previous ABA talks. Imagine a machine that is constructed so perfectly that it works beautifully for 100 years. And then the day it turns 100, it just collapses completely, right? So you can imagine that's the ideal of aging, right? I want to be super healthy and productive until I am 90, let's say. I don't want to live to 100. I want to live to 90. And then I just want to die in my sleep on my 90th birthday. That's my ideal aging, right? And so that's sort of Jim Freese's idea of compression of morbidity, right? And so geriatricians recognized that prevention of disease alone was not adequate, but we also require enhancement or improvement of functioning. So we want to avoid sharp declines in function and strength. And so the major goal became how to identify older adults who are at risk for dependency. And so thus evolved the concept of frailty. So frailty sort of denoted this underlying risk for really adverse events so that people become dependent and they cannot function independently in the community. So that frailty became a risk factor, or denoted that state where people are at high risk for becoming dependent. Right. So 1990s and 2000s, the first decade of 2000, saw an explosion of research on frailty. And if you do a PubMed search now, you'll probably see thousands of articles on frailty. And I think two of the seminal papers were our own Linda Fried's 2001 paper, and Rockwood and Midnitsky also at the same time, 2001. So these two papers sort of pushed the field forward considerably. And also simultaneously in 1987, Rowan Kahn published a seminal article in Science on what he called successful aging and contrasted it with usual aging. So he said just because people don't have overt diseases doesn't mean that everybody is doing well. So he looked at the group of people that didn't have any diseases, and he characterized that there is a great deal of heterogeneity even within that group in terms of people that are high functioning and people that are not so well functioning, but they didn't have any overt diseases. So he said we really need to characterize and go beyond the disease framework. And he also emphasized assets rather than deficits, right? I think the compression of morbidity and frailty framework tended to emphasize the deficits. So they were preventing deficits, whereas he wanted to emphasize the assets that people have, how to maintain assets and how to enhance assets and things like that. So he said it was not enough to simply avoid diseases. You need to do more than that. Um, so my understanding is that resilience is a product of this line of thinking. And in fact, it was interesting for me to note that in Rowan Kahn's paper in Gerontologist 1997, he actually discussed resilience as a dynamic version of successful aging. So he actually said that successful aging is not a static concept. So when people are exposed to stressors, they can go out of successful aging stage temporarily, but then bounce back to successful aging state. So he actually recognized the idea of resilience there. Um, so now I'll get back to resilience and how to characterize it. So the Merriam-Webster dictionary defines resilience as a capacity of a body to recover its size and shape after deformation, right? This is a very engineering definition, especially the strain is caused by compressive stress. It's also called elastic resilience. So you can imagine a spring and you load the spring with some mass, and so the spring is going to stretch. And then once the mass is released, the spring will go back to its baseline. It'll oscillate a little bit, but it'll go back to its equilibrium state, right? And another definition is ability to recover from or adjust easily to misfortune or change, right? And the general idea is that you bend but don't break. So that's the idea of resilience. And I saw a very nice paper in the psychology literature very recently, which I thought was very nice. So I will just read this. It says, although people may possess characteristics associated with resilience, whether people actually exhibit resilience can only be defined in terms of their level of adjustment after a stressor event. Resilience cannot be defined in the abstract or applied to individuals in the absence of an extremely aversive experience, such as loss. You have to note this comes from the psychology literature. So you can substitute extremely averse experience with some sort of a clinical stressor, like a major surgery or having like a cancer treatment or something like that, right? So then they say it is uninformative, if not meaningless in this framework, to describe someone as having resilient personality because resilience is defined ex post facto. Indeed, the psychological study of resilience mandates that we operationally define resilience as an outcome following a highly stressful event, and then document the factors that appear to promote or detract from that outcome. So I thought it was very interesting that they view resilience as an outcome that we cannot define or study in the absence of a stressor. And by the way, Mazzini and Bonanno especially, I think he's one of the leading psychologists who studies resilience at Columbia University. There are a number of papers related to bereavement and spousal loss and things like that, where he has conducted longitudinal studies looking at resilience. Okay, this concept of resilience is very rich. There's a paper by Wyatt et al. In 2019 where they cataloged 251 definitions of resilience. Of course, you know, there's a lot of overlap across these definitions, but you could probably take the spectrum and you can see that there is a wide spectrum of characterization of resilience. Especially in fields like ecology and engineering, resilience has been studied much longer. And I already alluded to the field of psychology and sociology. They did not include psychology and medicine from their definition. So you can imagine, you know, it probably is even more richer if you include psychology and medicine. Okay, so some of the definitions, I'm not going to go through them. I just wanted to show how rich the concept of resilience is. So this is a common characterization: the speed at which the system returns to equilibrium after displacement, irrespective of oscillations, or the measure of persistence of the systems and the ability to absorb shocks or changes. And this one I like, the ability of a system to maintain its identity in the face of change or external shock. So the identity meaning that it's not necessarily about, quantitative changes. Even if there is some difference in quantitative changes, but the system is able to maintain its essential identity. You are able to do whatever functions that you were doing before the stressor. And so there is no qualitative shift in your lifestyle or functioning. So that's the idea of maintaining identity.
Okay, Ravi,
And yes.
Do we wait until the end for questions? Is that how it works?
No, you can ask. Go ahead.
No, I think it's really fascinating your definitions, because I've been thinking a lot about community resilience and what a conundrum it is in the face of individual resilience, because sometimes they don't match up. Sometimes they're not the same. And what does that mean? And also I've been thinking a lot about communities, and I've been thinking a lot about Hurricane Maria. It's the 3-year anniversary was just last week, and in Puerto Rico. And I've been thinking a lot about palm trees versus fires and pine trees, and how important the actual environment is when thinking about a resilience. That it's like there is a very big third factor, of the environment. Palm trees are flexible and they move and they can withstand hurricanes, as opposed to a pine tree, which cannot do that. It's sturdy. It's gonna withstand the pound, as opposed to flex with the pound. So it's all that to say, just environment has been something I've been thinking a lot about, and the idea that sometimes the group narrative or the group think is different from what the individual needs as far as resilience, and what does that even mean, when you look at it from different perspectives. And just
absolutely,
the number of different ways to define resilience.
Yeah, sure. I think it's a very rich concept, and there is no need for us to stick to established characterizations, So if the factors of environment and support systems are very important in characterizing resilience, I think we need to bring them in. And also your idea, I had a slide which I took out, I call the Aesop's fable, the robust oak and the resilient reed, idea, right? The oak tree is very robust, it absorbs the shock, like panel B of this graph, right? You don't see any blip in the performance. It just maintains, but then it depends on the magnitude of the stressor, right? If the magnitude increases beyond a certain point, it just collapses, right? Whereas a resilient system can absorb the shocks, through social support or whatever, even though it bends and it can show some decline, like in panel A, but it can bounce back eventually with social support or other environmental factors. So yeah, I agree. I mean, it's not a simple definition that can be given for resilience, right? Yeah. And it's actually interesting, like, something like a panel F in here, they define resilience as, survival, right? If we can survive, that's still resilience. Because the alternative is that you just don't survive the stressor, right? So, it just depends on the context, I think. Yeah, so as I said, in ecology, this has been studied a lot. In ecological resilience, I think Chris Hollings is one of the first ones to characterize this. He used a dynamical systems framework for studying this, and he said that a resilience is staying near one of multiple alternative stable states, right? I'm a little bit not clear about this, because some of the alternative states could be much inferior or stable states, right? So if you're pushed from a good stable state to an inferior stable state, is that still resilience? I'm not sure. But in any case, so there are a number of examples of that in ecological literature, which I'm not going to go deep into. So this is sort of the pictorial representation, right? You can think of, it's a very abstract representation. So you could think of health as represented by this sort of, um, you know, uh, parabolic things put together here. So here is a state where it's an equilibrium state, right? You can imagine the state of a system here. And when you perturb it, it goes up and then it sort of comes back to its original state. So meaning that it maintained its original equilibrium. If you push it hard enough, it can go from this state into another state, right? State C. So in state C, it's a different equilibrium altogether, but it's a stable state, right? So depending on whether it's a better state or a worse state, you could qualify it. You can call it a resilient behavior or a non-resilient behavior. And another way of showing this, this is a more dynamic picture. So you can see here at the very first plateau here, you can imagine that's a young person, right? A young person has only one stable state, which is a healthy state. And then at the very end, you can imagine an old person, right? So the age axis is sort of like along this axis here. So if you go from a very healthy state to a not so healthy state, right? But you can see how the plateau is changing as a person is aging, right? You have now these multiple states emerging, right? So you can think of it as pre-frail or frail or whatever, right? These frail states are emerging now. So now in one of those intermediate states, if I push the system, it can go from this state to another state of equilibrium, right? So that's the idea here. And in engineering, again, there's a lot of examples in engineering, and I just don't have the time to go into that. But the same idea that you perturb a system and see how long it takes to get back to equilibrium, right? That's sort of the dominant idea in this engineering models. And it's very quantitative. They just want to see how long it takes to establish original conditions. So this is a nice example from Hurricane Sandy. You can see the number of households that before Sandy hit, there were like 2.2 million households. And then when Sandy hit, less than 1 million households had power. So there's a huge number of households that lost power, but then power was restored eventually. So you could look at this recovery dynamics as sort of a measure of resilience of the power grid, or that system, right? Okay, so I'll get to the main thing, which is resilience in aging, right? We call it physical resilience because we want to separate it from psychological resilience or cognitive resilience, right? The NIA had a symposium back in 2015 or 2016, I don't remember. So there were a lot of discussions about how to define resilience and things like that. And so they define resilience as the ability to resist or recover from adverse effects of a stressor, right? Because here they have the notion of resist, right? So this is sort of related to robustness, and then Karen, myself, and Jeremy wrote an article sort of fleshing out some of the nuanced ideas about resilience, in particular how to look at it from a dynamical systems viewpoint and how resilience may relate to frailty. So we define resilience as the ability of a system to recover from perturbation of a sufficiently large magnitude, right? That's what, if you go back to Mancini and Bonanno's, they mentioned it has to be a severely adverse event like a spousal loss or something like that in the psychology literature, right? That the system is pushed into a state far from its original equilibrium state. And ultimately, the system is able to retain its essential identity and function, right? So in order to do this, we must be able to define the features whose identity is retained, as well as the nature and degree of perturbations. And you can represent it pictorially like this. So imagine three people here, right? The blue triangle is a person who is robust. So their pre-stressor state is this. And then after the stressor, they essentially maintain the same level of function or phenotype. So we would probably call them robust, right? And here is a person who's a circle, like orange circle, and they declined a little bit, but still they did not lose their phenotypic identity. They're able to perform all the functions that they did before. And so we would call them resilient. And here is a person that declined substantially. So now they lost their phenotypic identity. You know, they had to probably get walker or get assistance of somebody to do certain chores that they were able to do easily before. So we would call such a person non-resilient, right? In this definition, right? And so we applied for this resilience RFA that NIA put out to study physical resilience. This was in 2016, and you know, we were surprised that we got funded. Pleasantly surprised, um, you know, and so we got this study to characterize resilience, but more importantly, from a novel perspective, what we call a dynamical systems approach to resilience. I think the previous people that have looked at resilience in aging literature did not focus so much on dynamical aspects of it. So I think that was one of the strengths of our proposal that was appreciated by the NIA and the reviewers, I think. So we got the opportunity to study this. And so what we did was we put together three different cohorts, three clinical stressors, where people of very different stressors actually. And I'll go into it shortly. So the goal of this study, which we call SPRING, because SPRING is a model of resilience, right? Study of physical resilience in aging. And the goals were to develop a framework by which to identify clinically relevant signatures of resiliency. Like, what do we mean by resilience? How does resilient trajectory looks like, right? In older adults undergoing different clinical stressors. And then to generate new measures, right? By which to identify individuals with impaired resilience to stressors. And then a more fundamental goal of advancing the biology underlying resilience, right? And so this is a framework that I have tweaked a little bit. Karen would be somewhat surprised by this framework, I think. But let me see if I can walk through this. So this is the predeterminants, right? These are all factors that are prior to stressor, right? One's age and psychosocial factors, health behaviors, disease, genetics, and so on. And then this box in here is a very important box. So this idea of physiologic reserve, right, is a very dominant theme in aging literature. In my view, it sort of connects the various disparate notions of aging, like frailty, allostasis, homeostenosis, you know, intrinsic capacity. All these are sort of tied together by this idea of physiologic reserve, right? You can imagine physiologic reserve as what is the maximum capacity of an organism, right? When I'm in my 25 or 30 years old, you know, I could multiply 4-digit numbers in my brain, you know, but now I can barely do, you know, 2-digit numbers, right? So you can imagine your capacity when you're 25 or 30 years old as your, you know, maximum potential, right? And then there is a basal level of capacity that is required just to wade through the waters, right? Just resting metabolic or homeostasis functions, right? But absolutely no stressor. But even to maintain the resting conditions, you need a certain amount of physiologic reserve, right? So the gap between the maximum capacity and the resting capacity is what you can call as physiologic reserve, right? And so this physiologic reserve um, is, um, is a strong determinant of the frailty phenotype, right? Which is measured by the 5 criteria that Fried and Karen and others have developed and validated. And so this frailty phenotype, we think of it as a determinant of one's physical resilience, right? As I said before, the physical resilience does not um, come into play until you have a stressor, right? So when there is a stressor, you can determine whether a person has a resilient response or not, right? And so that response can be measured at different levels. You can have a physiologic response or a phenotypic response. Physiologic response could be like looking at the response of autonomic nervous system, blood pressure, heart rate, things like that, or endocrine signals. And the phenotypic response could be gait speed or accelerometry measures or things of that nature, right? And so these responses can be utilized to characterize the physical resilience, right? Or you can say the physical resilience is actually defined by how people respond. And then these are, of course, related to long-term clinical outcomes, right? So this is one framework. And then this physiologic reserve, we would like to get a handle on it. So one way to get a handle on it is through this, what we call micro stressors or stimulus response experiments, right? You could perturb the system with micro stressors like glucose tolerance test or something and see how the system responds and how fast it takes, how fast it recovers to its baseline. So we can use that as a model system of resilience to characterize how the system may do under real life conditions. And so getting back to the spring study, so we have these 3 clinical stressors. One is called rebound, which is leukemia patients who undergo bone marrow transplant. As you can imagine, this is a very severe stressor because a person's immune system is completely wiped out and they are given new immune system from a healthy donor, right? The idea is that the new immune system will be able to fight the tumor cells, right? Because the theory now in cancer is that cancer is really a result of these rogue cells evading the surveillance of the immune system, right? So if you can fortify the immune system, you can fight off cancer better. So there's no better way to get a better immune system than a healthy new immune system. So that's the idea in bone marrow transplant. And then another stressor is hemodialysis. So where patients who have failed kidney function, end-stage renal disease, right? So they get dialysis to restore their kidney function. And then the third stressor is restore, which is total knee replacement. So older adults, osteoarthritis is a very common condition. So there's a lot of pain in the knees, and that severely restricts mobility and function of older adults. And so when they get this knee replacement, many of them, a vast majority of them, have extremely good functioning and they're able to do really well. In fact, this is an example where resilience is really a substantial improvement of quality of life and function compared to baseline, right? Whereas previously we've been talking about recovery to baseline as our metric of resilience. But here, recovery to baseline is probably not as good. You want to do better than baseline, right? So these are 3 very different challenges that we were fortunate enough to put in our study. And so I already mentioned briefly about the stimulus response paradigm. So here the idea is to perturb the system with a finite stimulus and study its response. And Karen, Linda, and Chen Li and I wrote a paper about this in 2008. describing a simple theoretical approach to doing this. This was, way before resilience was even on the radar screen of most people, at least in geriatrics. It was in the psychology field, but not in geriatrics. Um, so here the response is typically biphasic. There's a stimulation phase and then there's a recovery phase. And the goal is to model the magnitude and kinetics of the response, right? So by looking at the kinetics of the response, like time constants and things like that, we should be able to say something about the integrity of the homeostatic systems. So this is how it looks like, right? You have a baseline, and then you stimulate the system at time t0, and this is the peak response, and then here's the recovery, right? So you can look at the recovery and compare it to the baseline, right? Were you able to achieve full recovery or partial recovery? How long does it take to get back to baseline? What's the area under the curve? Things like that, right? All of these can quantify the nature of response. And here's a simple model, like, you can think of this as the HPA axis, for example, right? Here is a stressful stimulus or a stressor, and it stimulates response in the brain. You produce corticotropic releasing hormone or something, and then it produces ACTH, and then it produces cortisol, right? And then the cortisol has a negative feedback, right? Because if there is no negative feedback, you'll keep on producing more and more cortisol, and the system just would not work. So you have to shut down the stimulus, right? So the cortisol has a negative feedback on the stimulating parts of the response. So when you model that system, you get all kinds of responses like shown here on the right panel. So you can see that there is a exaggerated response and immediate recovery, or exaggerated response and slow recovery, or less response but really damped recovery. So you can get all kinds of responses, and these responses would give rise to different types of rate constants and area under the curve and things like that. So we could make use of all of this information to characterize resilience. Okay, and in spring we have a number of dynamic tests that are put in. The ACTH stimulation, which stimulates the HPA axis, and then we also have salivary cortisol measurements. This is not a controlled stimulus, but this is real life stimulus, like in day-to-day activity, how people are responding, right? So you measure cortisol response. So the only difficulty with this test is that people may be undergoing different amounts of stressors in their real life. So it's sort of not normalized, in that regard. And then the oral glucose tolerance test is again a controlled stimulus response test, where you give people an amount of glucose, and then you measure glucose and insulin response. And then Jen Schreck and others have this treadmill fatigability assessment, which is also a very useful stimulus response experiment. And then Holter monitoring, you can look at the heart rate response as people are undergoing these stressors, as well as in their day-to-day activities. And then we have some ex vivo tests of stimulus response, and then orthostatic blood pressure, which is how the blood pressure changes when you go from a supine position to an upright position. Okay, so I'll now get to my question of, is resilience a fad or real deal, right? I just want to say, what is a fad? A fad is a practice or interest followed for a time with exaggerated zeal, right? So I don't think we have exaggerated zeal. We are pretty balanced, I think, in the way we are approaching this. But still, that's how a fad is defined. And a fad is ultimately something that is discredited because its basic tenets remain uncorroborated by research findings, right? Findings that meet epistemological standards of logic, right? So eventually the research investigations done by a variety of investigators, is going to bear evidence on whether this is fad or it's a useful concept, right? And so in that regard, I just want to say that one way maybe you could argue that it's a fad is that resilience is simply frailty, but it's just repackaged in a more attractive way, right? So are we simply repackaging to sound optimistic? Because a lot of people just say that, oh, frailty is too negative. You know, we want to focus on something positive. To me, that's not a good way to think about it, right? Just because you refocus something as positive doesn't mean that it can really contribute to your, understanding of the aging process or eventually improve the well-being of the older adults, right? So we don't want it to be a simple repackaging. This is what is done in a lot of, management and organizational behavior things, right? They just keep on rewriting their mission statements, just to sound politically correct or more whatever. And so my answer, and also, the Duke group who have been leading the resilience research for quite a while, our answer is no, I think. Um, so here are some of the reasons, right? Some of them are from Duke group's paper, Heather Whitston's paper, and some are from our own paper. So we say that resilience applies across lifespan, but frailty applies in old age, right? Evening of life, right? I mean, this is okay. It's all right as an argument, but it's not like super convincing, yeah? Because you can talk about resilience of young people to stressors that they face in life, and things like that. So yeah, in a way, resilience applies across lifespan, right? Um, and then the other point is that resilience cannot be quantified using frailty phenotype. This is a very interesting point, I think, something that's worth really thinking about. They didn't really describe this properly in my mind. So I thought about it, and this is what I understood. I would love, Karen or others to also weigh in on this. Like, my thinking is that the phenotype is too coarse. It's designed to capture late life declines. It's not optimal for capturing midlife performances because you're sort of focusing on, like exhaustion and weight loss, for example. They're not necessarily ideal for midlife criteria. So you could probably redesign a measure that's better than frailty phenotype for capturing resilience or lack of resilience, right? In other words, you want to be able to detect departures from, optimal physiologic reserves earlier, So the measures have to be sensitive. I don't think frailty phenotype is sensitive enough to detect drop in resilience or drop in physiologic reserve. And then resilience is a dynamic construct, right? So you need pre-measurements, intra-measurements, and post-measurements, right? It requires specification of a triad of entities. You need to specify what the stressor is, what the system is, what the state is, right? Whereas I think of frailty as a global vulnerability to stressors, right? You don't have this level of specificity. And as I just want to reiterate Mancini and Bonanno's paper, without stressor, there is no resilience, right? And then another point that we always talk about is the idea of resiliencies, right? The NIA paper emphasizes the idea of resiliencies. This goes back to this triad notion, right? There is no such thing as a single resilience. Depending on what the stressor is and what the system is, you could think of different resiliencies, right? Okay. So now getting back to, is resilience a fad? We don't think so. I think the NIA agrees with that because they funded us. Is it the real deal? This is to be determined, right? And spring study is the first of its kind. I think, I can say this without any hesitation. This is a super, super unique study in the annals of aging literature. Lots of exciting data, abundance of research hypotheses waiting to be unearthed and tested, right? We can greatly benefit from your energy and creativity. So if you're interested, feel free to contact Brian, Karen, Chenley, or me, right? With that, I would like to thank you for your attention. And thanks to, again, Karen, Brian, everyone for this opportunity. And I'll be happy to answer any questions.
Thank you, Ravi. I'm going to myself clap, and maybe I'm inclined to say let's put the slides down so that we can see each other.
Okay.
And just open it up for questions.
There were some comments I didn't pay attention to, Karen. Sorry. I had the full screen mode, so I didn't see them.
Yeah, I don't think any of them was really a question. I'll throw one out to start, just to quickly warm us up. And so I got thinking about resiliencies as I was looking at your figure, which I like, by the way. I like it. You know, so does the notion of resiliencies, is that tied to basically the effect modification that you show through the stressor? You know, different types of stressors basically channel the impact of the reserve differently? Or is it different aspects of the constellation of reserve which are relevant to different types of, you know, outcomes or stressors? Or is it both? How do you think about that?
Yeah, I did not think about the second way that you characterized the different types of physiological mechanisms or homeostatic mechanisms that are relevant for the stress response, right? I didn't think like that, but it could certainly be that, Karen. I was thinking more in terms of different stressors and also in terms of what is it that primarily you're interested in terms of phenotypic response. Is it physical function or is it cognitive function? You know, things of that nature. So both different stressors and different types of phenotypic responses could, for example, you could be physically very resilient, but cognitively not so resilient, right? Could be one way to think about that. And yeah, I mean, different stressors, obviously, you could be very resilient to surgical stressor, but not so much to infection or or psychological stressors, or you know. So just to leave that open, it's still an open hypothesis, I think. You know, the idea that there is resiliencies doesn't necessarily mean that that is the right way to think about it. I think we need a lot of empirical evidence to weigh in on that. It could just be that there is still, you know, you can get a lot of mileage from a global resilience construct, just like in frailty.
Yeah. Thank you. Other questions or comments?
Ravi, this is Peter Abens. I have a comment and a question. The comment is that when the longitudinal study was started, you know, when people got sick, they were actually dropped out of the study. So the idea was to study normal aging, and I think particularly Dr. Schock, but Andrews as well, they probably made a mistake, but they were so concerned about stigmatization that they avoided disease. And it was really until Dr. Butler came into the NIA and made the point that Congress will never give money for studying normal. You have to have outcomes of diseases to show that you're benefiting people. That attitude changed. At least that was my perception, being a little bit involved at the beginning. But I want to challenge the approach of excluding cognition and mood or emotion. And I would ask you, what is the system in the three studies? What is the system that you're studying? Is it the whole person? Is that the basic system? And I always thought it was a mistake in frailty to exclude depression. I know it's complicated, but to think that cognition is not physical seems silly to me.
Yeah. Yeah.
I mean, it's a different organ maybe,
Yeah.
but,
Yeah.
but
Yeah.
if you look at outcomes, if you look at function as an outcome, I think it's pretty clear that that outcome can be influenced by what we're going to call physical abilities here, physiological, the things you're measuring, but also by cognitive capacities and some kind of psychological element. And that maybe ultimately you need to move that way. But I think if the validation of resilience is going to be to predict outcomes, and that's really what validated frailty, in my opinion, I think you're going to lose a huge amount of the variance if you exclude the psychological. That's just more, maybe, I don't know if
Yep.
there's a question in there
I
or a
think
comment.
no. I kind of get the question. Even though we call it physical resilience, our study is very broad, and we did not limit ourselves to assessment of physical function alone. We have a battery of cognitive depth, the batteries that we have employed, and we have a variety of psychological measures. Melissa and others are leading that aspect of the study. So we have not confined ourselves into a narrow view of looking at resilience. But of course, the emphasis, because of the way the grant structure was set up, was to focus on physical resilience. But we truly understand that is, the separation of physical cognition and psychological is very difficult. I mean, conceptually you can separate them, but you probably are doing it, at losing a lot of valuable information in the process. And so maybe Karen, do you want to add to that?
I can add in just a second. I'm keeping one eye on the time, and so as usual, I want to pause, recognizing I want to be respectful of people's time, and so understanding that some people may need to leave. Why don't we unmute and at least clap for Ravi? I thought it was a wonderful presentation. So Ravi, thank you so much. And then anyone who needs to leave, please feel free to go ahead and leave. It's been wonderful to see you. Those who can stay for a little bit longer, we can continue this conversation for another 5 or 10 minutes. And, yeah, I would echo what Ravi said. The NIA put a very specific structure on the projects that people were to pursue. The NIA actually partitioned resiliency studies into cellular, physical, psychological, and cognitive. But the point about frailty is well taken. And, I'll say that my own viewpoint is not that mood or cognition is not important, but I worry about conflating it, the various dimensions together, and would prefer to try to assess each dimension in its own right and then study interactions between them. And the one other thing that I guess I would respond to Peter's comment is that from our viewpoint on frailty, to predict risk of adverse outcomes is not the end-all validation. There's other aspects of the validation having to do with a syndrome of loss of reserve and hypotheses about the underlying etiology that also come into play. But I'll leave it there so as to not get pedantic.
Yeah, no, I agree. I think if the goal is to predict outcome, I think it's a relatively easier goal. You can do it by just collecting a whole bunch of measures and throw the whole kitchen sink at it. And these days with deep learning and things like that, you could just come up with a very good prediction model that gives you absolutely no insights into what is going on. So I think the goal is much more ambitious than just predicting outcomes. I think these constructs, our goal would be to advance our understanding of aging process, at least in some way. That's what I said, if resilience is not to be a fad, it has to contribute in some way to our understanding of aging process itself. I think that's probably, Karen, related to your point of trying to get at are there different homeostatic mechanisms that are involved, you know, in different types of stressors? Yeah.
Amal posted an interesting question. Amal, do you want to go ahead and ask that question?
Sure. Hi, Ravi.
Yeah, hey, Amal.
Long time. I haven't seen you in a while.
I love your background. That empty look is wonderful.
Oh,
Yeah, this is where I live now. Yeah, my question was kind of conceptualizing resilience and thinking, do you think that resiliency is aging immune, or do you think aging does affect resiliency? The reason why I'm thinking about that is, if it is immune to aging effects, why not just treat resiliency and forget about aging?
Like what exactly do you mean by aging immune? Can you
So I was looking at your graphs, and you were saying recovery back to baseline. And some people might recover, but not quite to baseline. And that little gap between baseline and their recovery may be due to aging. That was my thought.
Yeah,
But
sure.
if resiliency is immune to aging, perhaps it's just they haven't recovered fully back to baseline. And it just got me thinking, well, is this concept like independent of aging? Is it part of aging? That's kind of where my question was going.
Yeah, so if you look at our conceptual figure, right, we had age as one of the predeterminants of physiological reserve, which in turn sort of determines your resilient responses. So age is definitely a factor. You know, a person in their late 60s or early 70s might respond very differently compared to the same person being in their 80s or, you know, mid 80s or whatever. So I wouldn't expect resilience to be completely aging immune. I would probably expect that to decline, right? You know, which could mean that, you know, either they, for the same magnitude of the stressor, it takes them longer to get back to their baseline, or for the same magnitude of stressor, they don't quite reach the baseline, there's a deficit, or for the same magnitude of stressor, they just decline, you know? Because if you have different magnitudes of stressor, then it becomes difficult to compare, right? Is it an aging effect, or is it the impact of the stressor, right? That's why it's a little bit tricky, that it's a dynamic construct where the magnitude of the stressor is potentially quite important to consider. You know, like things like knee replacement, right? You could probably imagine it's the same procedure that's done on everybody. But even there, you know, one could argue, is it the same magnitude for everybody? You know, for some people, the surgery goes very well. For some, there's a lot of tissue that has to be removed. There is more bleeding, or, you know, whatever the way in which the surgeons would characterize the intensity of the surgery. You know, but it's you know, some of those are difficult to capture, but we are trying to capture in our study. We have you know, measurements of that that we could utilize.
I think we have time for maybe one or two more questions, and I want to first see whether any of the trainees would like to dive in, and you don't feel bound to, but I just want to make sure that there's a space to. Seeing none, Michelle, you want to go ahead?
Yes, thank you, Karen. I'd like to follow up on a really wonderful dialogue and question from Amal. Great piece, Ravi. I think this is always my favorite. I love hearing you speak about this. And what I thought maybe Amal was asking, perhaps I was provoking it to its extreme levels, whether aging is a component of resilience. If you were to account for, if we had a measure, let's do a thought experiment. If we had a good metric for accounting for resiliency, even across systems, let's say it's variability, speed, something that could absorb that variance, how much would be left for aging? Now, that may not have been Amal's question, but it kind of led me to think that might have been part of his question, that aging may be a component of resiliency rather than vice versa. Does that make sense?
I still don't get the question, Michelle. So So
Yeah,
variance means what are you trying to explain? What's the outcome that you're trying to explain?
vulnerabilities. So when you get perturbed
Vulnerability, like you mean?
to disease or to injury or to anything. So just like the palm tree analogy, you know, what if you, because there's so many young people who are not resilient when it comes to mental health. And so, you know, I think that our challenge is to find and understand this metric across systems. And we do know there are a lot of people who are not resilient right now. I mean, they're trying, but we're in a very artificial situation right now where we've isolated people in an unnatural way. We're trained to be social. We have this unfortunate natural experiment where many people, the suicide rates are going up. So, and these are across the age spectrum. So, you know, from the standpoint of mental health, you know, the idea that aging and resilience go hand in hand is actually, that's violated. So when I think about Amal's question, I guess I don't have an answer. I think you are, you know, a great thought leader in this. So just thinking about that question and applying it to physical function, I don't know if the same could apply, that resiliency is actually something that maybe
to psychological function.
Well, no, let's just take that analogy and then apply it to physical systemic, you know, whatever explains physical frailty. Could there be a similar analogy to what I just described, where your resilience is tested, and regardless of your age, it accounts for more variance in your response than your age does?
No, I mean, my understanding is that there is no such thing as resilience. See, that's why I put out that that Bonanno thing, right? That's, you know, I said your resilience is intrinsic. It is a verb, not a noun, in the sense that you can have a resilient response, right? The response is resilient or not, right?
I agree with you there. Yeah.
So I can, you know, I can look at someone's response to COVID, for example, and say, is that a resilient response or not, right? Mm-hmm. So did COVID affect them in ways that it destroyed their phenotypic identity in some way, or they were able to just keep on doing the same functions that they did before COVID? You know, of course, they may have to modify their lifestyles and other things, but they still were able to draw on resources to be able to do that, right? And if you say, does age explain, how much does age explain, you know, in this sort of resilient response, right? I don't know. I mean, I just, yeah, I feel like age should explain, you know, a reasonable part of variance.
Oh, I agree. I think kind of going to Peter's question, if you take it from the mental health standpoint, age is not as compelling in so many of our examples. And I agree with you about resilience. I agree, if I understand you correctly, that it's the manifestation, the behavioral or the expression of something that's latent. But I can say to you from a mental health standpoint, resilience, or the expression of resilient response to adverse situations, transcends age, you know. And so the challenge we have is, when we think about multiple systems, how do we speak about resilience across these systems?
Yeah, to me, I was going to say, you're raising the importance, I think, again, of maybe multiple domains of reserve, mm-hmm. right? Absolutely. And, you know, age may impact some of those domains in one way. And then Kat Moon, before she had to leave, posted a good comment that, who knows, maybe certain types of, you know, psychological resilience may actually increase with age.
Yes.
And, you know, so very, very interesting discussion.
We agree with that. I think that was a great comment. And wisdom would be one exemplification of that. But that's exactly, but again, it's a question. I don't feel strongly that there isn't some metric.
Yeah.
I'm just saying that your talk and then Amal's question provokes that, because in cognitive aging, we talk about biological aging and other factors. And there's this huge, it's a never ending debate about what's biology and what is actually experiential.
Mm-hmm. Yeah.
Well, I would suggest, why don't we close the formal session? And, you know, thanks to everybody. Thanks for Ravi for a wonderful presentation. Thanks for a robust discussion. And, you know, I guess Brian, is there a way we could even leave the thread open for people who want to stay and keep going?
I'm happy to. I am going to stop the recording at this point.
Absolutely, yes.
Stay on a little longer. I can leave it open, definitely.
Yeah. And then for we'll close the session and wish everybody well, and thanks so much for joining. We'll look forward to seeing you next time and to putting together a more social gathering as well.
Thank you.
Thank you.
Thank you.